We recognize that statins are the primary therapy that we have for the primary and secondary prevention of cardiovascular disease. And LDL cholesterol has been the target and used to determine when to start and when to potentially adjust lipid-lowering therapy. But I think there's emerging controversy, and research continues to question whether, in fact, LDL cholesterol is the best lipid measure for predicting cardiovascular risk, or, in fact, whether it can measure the effect of statin therapy. And so the authors in this particular study were concerned and sought to evaluate the relative strength of the association of LDL cholesterol, non-HDL cholesterol, and apolipoprotein B with cardiovascular risk in patients who were actually being treated with statins. So the study looked at individual patient data on over 60,000 patients in a meta-analysis and included patients from randomized controlled statin trials between 1994 and 2008. And what they found was that levels of non-HDL cholesterol among users of statins were linked to the risk of developing a major event more strongly than, in fact, the level of either LDL cholesterol or apolipoprotein B. And so these findings, I think, are interesting and challenge all of us to think a little bit more broadly about how we might use other lipid markers to understand the overall atherogenic risk in a given patient. Now remember that non-HDL cholesterol is the total cholesterol minus HDL. It is a secondary endpoint in existing U.S. as well as international guidelines, such that if LDL cholesterol target is, for example, 100 milligrams per deciliter in a given patient, that a non-HDL cholesterol goal should be less than 130 or no more than 30 points above your LDL target goal. So I think these findings are certainly interesting, and given that many have argued whether we need other surrogate markers for risk, it seems that non-HDL cholesterol is a very simple, easily measured lipid fraction that might be an appropriate target for statin therapy. So the study, I think, is interesting. I think it adds information. I think that overall the analysis has done a nice job trying to tease out the differences in LDL or apolipoprotein B and non-HDL as risk. But I think that right now, today, we know that an LDL target of less than 70 is appropriate and improves outcomes in high-risk patients. We know that targeting LDL through statins in multiple clinical trials improve outcomes, and that as much as this is an interesting finding, I think it'd probably be premature to primarily target non-HDL rather than LDL in our patients. I think that using non-HDL as a secondary endpoint and tailoring therapy accordingly once LDL targets were met is evidence-based and guideline-based, and we'll really have to stay tuned to see whether additional studies bear out the importance of non-HDL as either a primary or secondary target for LDL lowering.